10 seconds, sir. We will allow to the attendance. Okay. So it's 3, 2, 1. Over to you, Hiren, sir.
Okay. Very good evening to all of you, and warm welcome to all of you in today's very interactive discussion on the topic: what should be your choice to reach the lipid goal? Doctor, this is very interesting topic to discuss today because we are facing a challenge of achieving the lipid goal in our day-to-day clinical practice when the patient is either having the plain dyslipidemia, only dyslipidemia, or maybe patient with dyslipidemia associated with other risk factors. And sometimes there are the multiple factors, which is the patient level, the level of the disease that are not able to achieve the lipid goal. So, what should be your choice to reach the lipid goal? That is what is today's topic. And for today's topic, we have expert a group with us. We have Dr. JPS Swane, who is going to moderate this today's meeting on this topic. Along with Dr. Swane, we have Dr. Samir Dani from Ahmedabad and Dr. Amit Kumar from Kanpur. So both are in the expert panel members meetings in a faculties. So they will give the a meaningful insight in today's discussion about the what should be your choice to reach the lipid goal. So if I briefly introduce Dr. JPS Swane, he's a senior consultant cardiologist and chairman of Department of Cardiology at Sir Gangaram Hospital, New Delhi. He's a member of the Sir Gangaram Trust Society. He's also a member of Executive Board and Board Ethics Committee and the Research Committee of SGRI, that is Gangaram Hospital. He's also a member of Delhi Medical Council and chairman of the Lipid Council of India, having 240 plus publications in various index journals and books. Also participated as a principal investigator in various clinical trials, having 50 plus awards during the educational and professional journey. He's a chairman for the CSA clinical practice guideline for discipline management that was published in 2024, and also part of many bridging the global clinical trials to the private sectors. That is what hospitals, the national coordinators for the steering committee members, and also we have many global clinical trials and registries. Also having the established the preventive cardiac rehabilitation programs in the country. So with this, I would like to invite Dr. JP Swane on the virtual platform. Along with Dr. JP Swane, we have one expert panelist for our today's meeting, that Dr. Samir Dani, who is a senior interventional cardiologist and CEO of Apollo CVHF Heart Institute and the director of Apollo Hospitals, Bhat, Gandhinagar, Gujarat. He's also honorable cardiologist of the government of Gujarat, having the more than 30 years of experience in the field of cardiology, having various awards to his credits, especially the Pride of Gujarat and Dr. B.C. Roy Award, which is the award that the most prestigious award that he has received, having many publications in various national and international journals. Also founder director of National Endovascular Workshop. Along with Dr. Dani, we have Dr. Amit Kumar in the expert panels. Dr. Amit Kumar is an international cardiologist and director at Department of Cardiology, KKR Hospitals and Heart Center, Kanpur, having more than 8 years of experience in the field of cardiology, and also associated with various prestigious institutes as a cardiologist, which include Udaipur, the hospital college at Udaipur, also the Max Hospital in New Delhi, and also the Mariampur Hospital at Kanpur, having more than 5,000 international procedures, and also in the publications and the legislation in the various national and international journals. Also member of various scientific societies, which include CSI, ISC, LAI, and the IMA. Also principal investigator in many reputed ongoing trials. Few trials like acclaimed lipoprotein A trial for lipodisiran and Trump outcome trial for the retatrutide. So with this introduction, I will hand over this virtual platform to Dr. JP Swane sir for further proceeding. Welcome, sir, and over to you.
Thank you. Thank you, Dr. Prajapati. Let me share my slides.
The screen is visible, sir.
Clear. Yes. Okay. So thank you, Dr. Prajapati, Dr. Mr. Gajendra, and colleagues from the areas. And also, I welcome my colleagues, Dr. Samir Dani and Dr. Amit Kumar, for this panel discussion, CME, a short CME on that. What should be your choice to reach the target lipid goal? I think what we have been doing, we have been for many years have been treating lipid with the monotherapy, and now we have learned that the alone monotherapy with statin may not be enough. We may have to use non-statin drugs to reach the goal. For that, we will just briefly go through this. I think both of this, everything is known to both of my colleagues. So I will just rapidly go through this. Can my voice is audible?
Yes, sir.
Good.
Dr. Is audible.
Yes, audible, sir.
Okay. So, so what we have learned so far that the LDL cholesterol has been the main target for management of atherosclerotic cardiovascular disease, and we have learned that with the magnitude and duration of exposure of LDL is a very important part of the pathogenesis of atherosclerosis. And we have also now evidence from the randomized clinical trials and the prospective cohort study of 12 years, randomized clinical trials for 5 years, and Mendelian randomization study of more than 5 decades have shown clearly that there is a log linear relation per unit change in the LDL cholesterol to the cardiovascular disease. The lower the better is the benefit, the effect of the treatment has been shown that you lower the LDL cholesterol, then probably you will be able to reduce the cardiovascular events. And Mendelian randomization study where the people, they have, because of the genetic predisposition, they are having low cholesterol level from very early childhood. So what we found that if we use LDL lowering drug in randomized clinical trial, both primary and secondary prevention of the cardiovascular disease by 80 milligram on average, the cardiovascular risk reduction is seen by almost 40%. Whereas when we use the genetic studies, the Mendelian studies where the loss of function of PCSK9 is known, the LDL reduces only by 40 milligram. That means the average LDL of USA is probably 120. And if it is reduced by 40 milligram, then when instead of 120, the level is 80 milligram in the population in this study group, the cardiovascular events are reduced by 80%. This is because the lifelong reduced exposure of LDL. Whereas in clinical trial, it is only 5 years reduction of the LDL exposure. So that led us to the concept that we should reduce LDL as early as possible, earlier the better, to reduce the lifetime risk of cardiovascular disease. So this become very clear that if we have low cholesterol from the very beginning in our life, then probably getting chances of getting future cardiovascular diseases is lesser compared to the other population. And then came a very good concept given by Dr. Horton long ago, almost now 15 years ago, that it is the lifelong cholesterol burden which is the important factor. So what he found that what is the cholesterol years? If the threshold for the cholesterol years is 8 gram, the cumulative LDL cholesterol of suppose 8 gram, then the atherogenesis starts, or atherogenesis is evident by that time. And for that, we have now proof that if general public, there is population, the LDL is 120, then generally they get cardiovascular disease at the age of around 64 to 65. This is the average age of the atherosclerosis in Western population. And we have also now learned that familial hypercholesterolemia, particularly the heterogeneous group, they have cholesterol level about 200, 250. And there we found they reach the threshold of 8 gram by the age of around 35 to 40. And that is the time when they start getting the atherosclerosis. Whereas homozygous, unfortunately, they have very high cholesterol, LDL, above 500 milligram. And then if you reach the 8-gram threshold, they reach 8-gram threshold between 12 to 15 years of age. And we have also found that if you have a LDL cholesterol 80 milligram, as I shown in my first slide, where there's a loss of function of PCSK9, so naturally the genetically the individual is having low cholesterol, they get disease almost in the 8th, 9th decade. So the disease is very rare. I mean, it comes very late in the lifespan of a patient. Now, the other interesting finding is that if you have hypertension, diabetes, and metabolic syndrome or tobacco coming up earlier in life, which we see in our country, mainly in South Asian population, and also we are predisposed to atherogenic dyslipidemia because of familial hypercholesterolemia, which is there in 15% of our population and 10% in the Western population, and high lipoprotein little a. If all these 4 or 5 factors are there coming up earlier in age, then the threshold is reduced to around 6.5 to 7 gram. And for that reason, why we Indian population, even in spite of having LDL of around 100 and 120, we get disease around 55 years of age, around 50 to 55 years of age. This is what the Interheart study showed. The average age was around 52. So that's how the explanation is that why Indian population or the population of the South Asian origin, they have earlier disease coming up because of the associated risk factor which they acquire earlier. And then we are predisposed to genetic factors, and we are also having central obesity as one of the important risk factor for that. Now coming to the how we can push this disease. For that, we have no data from the familial hypercholesterolemia group, which we have got data from our country also now. That if you start statin at the age of 10 or at the age of 20 in this young adolescent, young individual, those who are carrier of familial hypercholesterolemia, we generally push the disease by almost more than 2 decades. Similarly, if an individual start taking the statin at the age of 55 or 60, then also we can push the disease by approximately 1 to 1.5 decades. So this is well known, this is the time. So that again proves that if you reduce cholesterol earlier, probably you get much more benefit. So having learned this, now that the question comes is that treat to target LDL cholesterol, target of less than 100 for general population, less than 70 for diabetic and hypertensive population, less than 55 for patient with atherosclerotic cardiovascular disease. And we know that the high dose of statin reduces by 50% and modest intensity statin reduces by 30%. So the question number one is that which approach is more protective, larger reduction versus target achievement? So I will request Dr. Amit to give his opinion on this part of the discussion. Dr. Amit, please.
Yes, sir. First of all, I'd like to thanks, sir, who have very nicely explained about the factor that the both magnitude as well as the duration of LDL exposure is important, and we have to reduce both. Means we have to reduce the magnitude also, and we have to reduce the duration of exposure also. So, in my view, the more protective way will be to achieve uh, the targets, which have been now very clearly established, that patients who are having diabetic or patients who are having very high risk, there you have to achieve a goal of LDL more than less than 70. And the patients who are having extreme high risk, means patients who are having recurrent coronary events or patients who have been having a coronary angioplasty done. There you have to achieve the goal below 55. That is very well established. So my approach would be the target.
Yeah, I think I agree with you. And Dr. Samir is there? Is he joined?
Yes, Dr. Sani, I'm there.
Samir, hello, good evening. Yes, you busy in the lab.
I'm so sorry. I was busy with an emergency, but I've
I
joined.
know.
I missed some of your slides, but more or less I'm with you.
Okay, fine, sure. So that's what we were looking for, and we have just had a discussion. I think the reaching the target is important because what we have learned that if a patient comes with ACS to us in the hospital and his LDL is above 110, above, for example, 120, and we have learned if you use only high dose of statin, we'll reduce by 50%. Then from 120, he will at best come to 60, which will be still above 55. So that's why we think that combination treatment in the beginning may be required in certain high risk population or very high risk population. Yes, I think I agree with you then. So let's go further. So the CTT trialist collaboration group of 21 trials in 1,29,000 with follow-up of on average 5 years have clearly shown that if you reduce the LDL by 1 millimole, there is a vascular events are reduced by almost 22%, and the myocardial infarction probably reduced by almost 24%. So on average, this is a good formula that the 1 millimole reduction reduces cardiovascular events by approximately 20%. So so it is desirable that we should keep it below 70 for high risk population, which are the people those who are having diabetes or hypertension with risk factors. And such target can be achieved sometime with alone statin, but sometime it may not be. You may have to use a combination treatment. So what we have learned over last few decades that in the beginning, the guidelines were suggestive that you keep the LDL to below 100 milligram in high risk very high risk population. So moderate doses of statin was used, and this was achieved. But then they found that residual cardiovascular disease was still existing. So then the guideline changed. They say no, you keep it below 70 milligram for very high risk population, and this was based on TNT trial and prove it trial. And they said, okay, we keep it below 70, there is a reduction of further cardiovascular events. But then also we saw that in spite of that, the residual cardiovascular risk was still existing. So there was the thought process came, why not reduce it to further below 70? But we have learned that high dose of statin cannot reduce the LDL in high baseline patients below 70 milligram. So non-statin drugs came, particularly the HMI in IMPROVE trial and then the PCSK9 inhibitors. And good news came from the studies were that either you use statin or you use non-statin, whichever method you use, if you reduce LDL by 1 millimole, the major vascular events are reduced by 20 to 22%, both by statin and non-statin drugs. So it became very important that the LDL reduction is the major factor, pleiotropic effect are probably secondary. And for that came the IMPROVE trial, first time published in 2015, and in 39 countries, average age was 64, patient with acute coronary syndrome were given simvastatin 40 milligram compared to simvastatin 40 along with 10 HMI, followed up for 6 years. And what we found, those who were alone on the high dose of statin, from baseline 100, their cholesterol came down to 69 on average, that means below 70. Whereas the other group, those who are on combination of statin and HMI, it came to below 55, that is 53. This is how the number 55 came in the in the guideline that in very high risk population, you have to keep it below 55 because these all patients were patients of acute coronary syndrome. And the benefits were seen in all the patients, but much more seen in the diabetic population. And then PCSK9, you know that they are available now in monoclonal antibiotic. They prevent the degradation of the receptors. And so more and more cholesterol is reducing from the serum. And this has been studied in the Fourier trial, where is the chronic coronary syndrome population using evolocumab compared to placebo on the background of statin with or without HMI, and keeping the cholesterol below on average 30 milligram and showing primary endpoint reduction and secondary endpoint, and the extended release 5 years extension OLE trial of Fourier showed reduction of cardiovascular event also. The good news was that even bringing it down below up to even 20 milligram, they was keep on having reduction of cardiovascular event in this high risk population, and the drugs were very safe. Even in such low level of cholesterol, there was no adverse effect which we could see, like the new set of diabetes or myalgia or neurocognitive function. And subsequently, within few months, the study came, Odyssey trial, which was an acute coronary syndrome, of course, 18,000 patient or 19,000 patient. Here, the average cholesterol came down to less than 40. And this is how the EFC guideline has chosen the figure of less than 40 for extremely high-risk population. So these are the ACS population getting recurrent coronary events also. And primary endpoint, the secondary endpoint increasing, including the cardiovascular mortality was reduced. So what we learned that if you go further down with the help of non-statin drugs like HTMI to below 55, there's a reduction of cardiovascular events. And even if you add further any one of the the PCSK9 inhibitors, even going below 40 or even below 30 has been found to be safe. But at the same time, there is a benefit of reduction of cardiovascular events. So this was the basis of using the combination treatment in high-risk population. So the other question comes now, is shall the statin for all the diabetics? So the efficacy of cholesterol-lowering therapy in more than 18,000 patients, 14 randomized clinical trial. The first trial was the CARD study, which was done in diabetic population where only 10 milligram of atorvastatin were given irrespective of LDL cholesterol, and it showed a significant reduction of cardiovascular events. So the question to my colleagues is, your views on initiating statin therapy for diabetic population. Dr. Amit and Dr. Sameer, I want both of you to give your opinion. Shall we use blankly this drug statin to every patient of the diabetes, or shall we not?
Yes, sir. I mean, if we follow, sir, Lipid Association of India guidelines, they have very clearly mentioned diabetes patients who are having 0 or 1 major ASCVD risk factors as high risk group. And the patients of diabetes who are having more than 2 ASCVD risk factors, or the diabetic patients who are having target organ damage, they have included such patients in very high risk group. So they have very clearly mentioned that the patients who are having in high risk group, their LDL cholesterol should be below 70, and the patients who are in very high risk group, their LDL cholesterol should be below 55. So in all patients, means by that guidelines, all diabetic patients should receive statin therapy, and the goal should be below 70.
Okay. Sameer, you want to say something? He's not there, maybe busy. So I would say that our own guideline from CSI also, which is mainly based on the ESC guideline also, as you rightly said, we were little different from the ESC guideline, which I will discuss subsequently, that the most probably every diabetic population will be requiring statin. Only thing is the goal may be different. As you rightly said, if a patient of diabetic having atherosclerotic cardiovascular disease, of course 55 or below. But if a diabetic patient having no atherosclerotic cardiovascular disease, then we have suggested to keep it below 70. Although we have added that diabetic along with one of the risk factors. So for that reason, probably one of the risk factors is always invariably present in diabetic population. So I think it looks like the majority of the diabetic population has to be on a statin treatment. So we always say that in any chronic diabetic population, the first prescription should be statin, followed by RAS blocker, and then the control of diabetes. Sometimes in very elderly population, high risk population, probably keeping the sugar level at a modest control, keeping around 7 to 7.5 may be good enough. But controlling the lipid is very much important. Similarly, coming to the other area is the area of hypertension, which is again like diabetes is a major risk factor. So shall we use statin in your views for every patient of hypertension? We have some data from the Escort LA trial on statin in hypertension, and then subsequently we had an HOPE 3 trial. Also, we found a significant of information coming in diabetic in hypertensive population that if you control the lipids, that is always better, that you will have a absolute risk reduction in those population. So those who are having hypertension diabetes combination, they are having much more aggressive atherosclerosis. So I think even simple hypertension patient without suppose diabetes is there, only hypertension is there, shall we give statin to all the patient or not? So Amit, what is your opinion on this?
I feel means only patient having hypertension does not qualify for means statin therapy unless and until there is another
ASCVD risk factor is also present. So, means this is my view. Means I want to hear from you, sir. Means about this. Means
That's
what?
right. In our guideline, we have said same thing, that if it alone hypertension is there, a young patient who is 30, 35, hypertension, no other associated risk factor, probably we need not give statin if his LDL is below 100. If the LDL is above 100, then in the general public also we say that you keep it below 100 for general population. For hypertensive patient, we in that situation we will be saying keep it below 70 because he comes under the high risk category. Now, what are the other associated risk factor? If you look into that, what we have suggested is, like for example, other risk factors are diabetes, dyslipidemia, the smoking, central obesity, and family history of premature heart disease. So any out of this 4 or 5 risk factor, if any single risk factor is there in a hypertensive patient, irrespective of age, it is better to keep the LDL below 70 because what we have learned that common denominator is the entry of the LDL or non-HDL cholesterol. Who pushes? Diabetes, hypertension, smoking, and stress. They push LDL. So denominator has to be reduced to less than 70. So that's what we thought that the hypertensive area, probably many times, many hypertensive patients are not on statin. So that is what we thought that this discussion is also important in managing the patient. This is what we have, our guideline have suggested now, that although we have atherogenic dyslipidemia, so we suggested that not only LDL cholesterol, but non-HDL cholesterol, which includes the LDL plus the LPA and also the remnant cholesterol present in triglyceride molecule, should be estimated. It becomes very easy, total cholesterol minus the HDL cholesterol, and you need not be fasting. So we have in our guideline, we have been very emphatic that non-fasting lipid profile should be done in majority of the patient, except for those patients, those who have got very high triglyceride. So in this risk assessment is showing that what we show, which we have just discussed, that diabetic with one risk factor, hypertension with risk factor, diabetic with end organ damage, hypertension with target organ damage, like for example, having LVH, having retinopathy, having macroalbuminuria, all these patients should keep it below 70. But yes, any hypertensive or diabetic having atherosclerotic cardiovascular disease, we should keep it below 55. So this is what we suggested in our guideline. And so the other area which is that the Indian patient are at high risk. Yes, we get risk factor earlier. And the understanding by physician on long natural history of atherosclerosis is not very good. Guidelines are not very clear. That's why our first guideline of India we produced after 4 years of research from our Indian population. So this was the first guideline. Earlier, all were the consensus treatment given by our colleagues. So even many patients are using very low doses of statin, even in high-risk population. Atherogenia, dyslipidemia is generally ignored. We keep on looking at LDL cholesterol in spite of having a triglyceride above 150 or 200. We don't look into non-HDL. So many times we have seen that we have reached the LDL below 55, but our non-HDL is above 85. So that patients we are ignoring in clinical practice, and probably we need to address that also, that target non-HDL cholesterol and try to reduce it below 85 for very high risk population. So the change in the CSA guideline after guideline, how do you see the trend in last 1 year after CSA guideline on the use of ezetimibe? Yes, that's a drug which we have strongly advocated as one of the drug to be used along with statin in significant number of population, particularly high risk and very high risk population. So Dr. Amit, your opinion for that?
Yes, sir. It's now very clear that with only use of statin, we are not able to achieve very low LDL goals, which have been recommended by the guidelines, that is 55 or 40. So we have to use another statin lowering therapy. And if we see the result of improved IT trial, where the ECS patients were used, and simvastatin plus ezetimibe group were compared, there they have shown that if you lower LDL below means 55 means up to 53, there is lot means reduction in the MACE. So recently we have seen that ezetimibe use has gone means it has been used very means frequently nowadays, and with the use of ezetimibe, we are able to achieve that goals which was not possible with the use of only the high dose statin, sir.
Yeah, you're right. Very good. Thank you. So the but the lipid-lowering therapy, the problem was the adherence and compliance. And Da Vinci study, which was done by Dr. Kaushik Ray in European 18 European countries, have shown that only 62% patients were above the target goal. So they were not reaching the goal. In very high risk population, high intensity statin was used only in 38%, and moderate intensity statin along with H was used only in 9% of the patients. This was a study from the Da Vinci. And our own study, which was then published also, a small number of patients, 575 patients from few centers in the country, and published in the journal. And then that shows for 11 sites in the country that 80% of the patients did not reach the target goals. One of the major reasons was many of the patients did not receive the high dose of statin. So what we did one study at our Gangaram hospital on our population of acute coronary syndrome, single center study on 3,700 patients, whom we put them on high dose of statin and or 80 milligram atorva or 40 milligram rosuvastatin. And we followed them up over a period of 3, 6, and 1 year. At the end of 1 year, only 30% of patients were high dose of statin. We started looking that majority of the patients were on 20 atorva and 10 milligram of rosuvastatin at the end of 1 year, within 1 year of the ACS. So we started looking into the cause. We interviewed 400 patients at the end of 1 year, asking them what is the reason why this dose has been reduced. So very few people came with the side effect as the cause, like myalgia. Probably that was justified, which we did in our guideline also. And cost was a major factor. Media might have played a role, but the majority of the patients in our country, they said it is their physician or their cardiologist who has reduced their dose without any reason. So when we asked them what was the reason for that, nobody had an answer for that. So they blame the physician, they reduce our dose. Now, why this was important? Because this 400 population, we asked them to repeat their lipid profile. And believe me, 90% of this 400 patient at the end of 1 year, they were above 55. Someone was around 100, 110, 120 because they were on not high dose of statin. So this practice probably needs to be changed. The education of the physician is also very important. Yes, if you get a side effect of myalgia or there is evidence of new onset of diabetes, you are justified in reducing the doses of the statin. But again, once you reduce the dose, please repeat the lipid profile again within 4 weeks, after 4 weeks, so that we will able to know if the person crosses above 40, 55, then we can add bempedoic acid to such population, those who are unable to tolerate because of new onset of diabetes or because of myalgia. So this is what we have learned from our study. So your comment on the challenges with the use of statin monotherapy. Yes, even with the optimized statin, greater utilization of non-statin is likely to needed to reduce the gap. High intensity statin monotherapy was used in 20% of the very high risk primary prevention patients and only 40% of the secondary prevention. So, Amit, what is your experience? How you find that this for primary prevention, particularly the use of statin? Amit is there or?
Yes, sir. Sorry, my internet was weak, sir.
Okay.
Yes, I feel that use of statin monotherapy can be sometimes challenging when you are dealing with the ACS patient, where goal is very means low. We have to keep the goal low on lower side, which is not possible only with the use of high dose statin. There you have to use another molecule like ezetimibe or bempedoic acid, which have very well have been accepted by patients without having much of side effect, as you have already mentioned, like common side effects, the myalgia which we see means if patient is complaining, definitely we are thinking of myalgia due to statin. Then we can add bempedoic acid or ezetimibe to remove that side effect, and we can safely achieve that goals. This is my view.
That's right. Yeah, for primary prevention, we know that use of this statin in modest doses is quite common, of course, but some of the patient may be requiring high dose of statin also for high risk population. So what we learned that the high dose of statin probably Sometimes, in spite of that, they are inadequate for LDL reduction. We must look for the risk for the cardiovascular disease. So, in our clinical experience and challenges with the side effect, cost issue, and physician inertia, which I have discussed with statin combination treatment, is there. So, moderate statin along with HMA probably will be better to control the LDL cholesterol, and it will definitely result in better cardiovascular prevention. So this evidence also came from the racing trial, which is a Korean study published in Lancet recently on 3,780 patients, follow-up of 3 years, patient with atherosclerotic cardiovascular disease. The one group received the high dose of statin, rosuvastatin 20 milligram. The other group received 10 milligram azithromycin along with modest doses of the rosuvastatin 10 milligram, and they were followed up. And this is the randomized open label trial. And we found that the efficacy of the combination of rosuvastatin and azithromycin was much better compared to that of high dose of statin. Although the primary endpoint did not differ much, there was a trend in favor of combination treatment, but the efficacy was very good in this population. And the number of patients, those who have got discontinuation of the drug because of the side effect, was also less in the rosuvastatin and azithromycin group. So the question is the comments on the proportion of patients achieving LDL targets in clinical practice. So what is your opinion about that? How many patients they reach the LDL target depending upon the risk, whether it's a high risk or very high risk population. What is your opinion in your clinical practice?
If we are using only statin and not using other means lipid lowering agent, then means I feel means we are not able to achieve LDL goals which have been recently revised in various CSI or ESC guidelines. So there we need to add other means lipid lowering agents because we means if I'm not having any exact means data for that, but it's my clinical experience means more than 50% of patients are not able to achieve their LDL cholesterol goal. Means when you are using only statin.
Yeah, because of the high dose of statin, sometimes it's not
Yes,
well tolerated.
sometimes it is not well tolerated, sir. Sometimes the cost issue is there when you are using high dose of statin, let's say 440 mg rosuvastatin, which is available generally in the market in price of 50 or 60 rupees. So it becomes very means costly sometimes for patient to continue such high dose statin.
Yeah, I agree. But I think those are the basic reasons what we found. But physician inertia is also one of the major factors
Definitely,
in our country.
definitely. Yes, sir.
Yeah. So the combination is, how do you feel now? As you rightly said already earlier, that the combination of statin is coming up in a big way in the country now. This is becoming a very common practice now. Many physicians are following that. They are adopting azithromycin as an additional drug to the statin treatment also. That is all. So based on that, when we published our guideline on 9th of April 2024 for the management of dyslipidemia acute coronary syndrome, we have suggested then non-fasting lipid profile should be done the moment patient comes to the hospital. Unfortunately, many hospital, even tertiary hospital, in the discharge slip, you have every investigation except lipid profile. So that becomes a challenge because we don't know whether this lipid has played a major role in the pathogenesis of MI in this patient and what should be the target we should achieve. So these two things are not available to you if you don't do lipid profile. And this was the practice. But now I can see that over a period of some time, now most of the hospital have incorporated along with the basic investigation, non-fasting lipid profile also. And we have taken that concept that hit hard and hit early because the ACS population, they get recurrent coronary events within 3 months, very high. So we have to stabilize the plaque within 3 months. So what we did, we have suggested that to start with rosuvastatin 40 along with azithromycin or 88 orva with azithromycin as a beginning drug in such population and wait for only 4 weeks, not 6 weeks, because this is the time what we found that when we did the study in our hospital, in our country, looking at the lipid profile of the patient with ACS on day 0, on day 7, 14, 28, and 42, what we found, the statin's maximum effect with the high dose of statin comes at 28 days. Beyond 28 days, there was no further reduction of the LDL cholesterol. So that's how we chosen 4 weeks as a second lipid profile to be done for such population of ACS, which are very high risk population. And if the levels are above 55 after 4 weeks, then we have suggested to add bempedoic acid and wait for another 4 weeks. If you're not able to achieve, then you have to add either PCSK9 inhibitor or inclisiran. Now, instead inclisiran is available, is now taking over because the added advantage that the drug has to be given only twice a year against 26 injection of PCSK9 inhibitor, and the drug has advantage that it does not cause fluctuation of LDL cholesterol, which has become one of the important cause of cardiovascular events. The variability of blood pressure is known, variability of heart rate is known, variability of sugar is very well known, and now we have a data which shows that variability of the LDL cholesterol is also not good. This has been seen with PCSK9 injection, but not with the inclisiran. And thirdly, the cost effectiveness of the inclisiran is much better. Now here we have suggested that end of 3 months, if you follow this algorithm, then most of the patient will be able to achieve below 55 or below 40, depending on the need, extremely high risk patient or the very high risk population. We have suggested, yes, you can down titrate the dose in the footnote if your patient has myalgia, or if a patient shows a rising trend of HbA1c. So we have also suggested that a patient who is admitted, he should not only get the non-fasting lipid, but also along with biochemistry and HbA1c, who is a non-diabetic patient or pre-diabetic patient. And if you found after 3 months the HbA1c is showing a rising trend, because we have a large number of population with atherogenic dyslipidemia and central obesity or pre-diabetic, then we can down titrate the dose from 40 to 20 or 80 to 40. But don't forget to repeat the lipid profile after 4 weeks. If the levels goes up above 55, then add bempedoic acid. If the level remains below 55, then continue with the low dose or lower part of the dose of the high dose of statin. So this is what we suggested and made it very easy or simplified for our population. Similarly, our guideline was the first guideline where we have given the algorithm for stable coronary artery disease population, because they are the patient where annual rate is not very high. So we are not in a hurry to reduce the LDL cholesterol. So a high dose of statin or rosuvastatin 20 or 40 at Orva is a good way to keep the LDL below 55. And a significant number of patients, when they are diagnosed as chronic stable angina, they may be already on statin. And there we have suggested that straight away ask them to add ezetimibe, because we have learned now the doubling the dose of from 20 to 40 of rosuvastatin or 40 to 80 at Orva will reduce LDL cholesterol by 6 to 8%. But in the same rosuvastatin 20 or Orva 40, if we add ezetimibe, we reduce the LDL by around almost 15%, almost double. And the added advantage is that the side effect of the statin is low, because the myalgia is again dose dependent. And secondly, the new onset of diabetes is also dose dependent. So these two advantages are there. So we reach the goal early, we reach the goal safely. So that's what we've learned. So we found that in such a chronic stable angina population or patient of stroke, then probably adding ezetimibe to even modest dose or at least the rosuvastatin 20 or 40 will definitely achieve the LDL much earlier. If you do not able to achieve, if your patient has familial hypercholesterolemia or very high cholesterol, probably adding inclisiran will be best way to go forward. So then question came that why there was a need for a guideline of our country. So far, as I said, for last 10 years, we had the consensus opinion and expert opinion based on the experts of the country, those who have interest in lipids. But the first time we thought that we should have guideline for our country, which has to be based on our population. And the need came because the more than 50% of population in our country, they get heart attack by 50 years, so less than 50 years. 10 years earlier than the Western group, almost 3 times more than Western group. And around 15 to 20% patients are less than 40 years, which is not seen in most of the part of the world. The second important reason why we wanted our own guideline, that we found that when we look into the data of prevalence of a country, a good paper by Dr. Mohan published in Lancet, that we acquired the hypertension, diabetes, and dyslipidemia probably earlier than other parts of the world. And secondly, among the tobacco chewing and BD smoking is again a unique risk factor of our country. And thirdly, the central obesity, what we say thin fat obesity of our country is again a very, very high risk factor for atherosclerotic cardiovascular disease, is double in our country compared to that of the Western world. And that's the reason why we get atherogenic dyslipidemia much higher in the country with high TG, low HDL, and small dense LDL cholesterol. And our own data of genetic causes of atherosclerosis has been found to be another important factor to discuss, that familial hypercholesterolemia is much more common in young heart attack patients up to the tune of almost 15% compared to less than 10% in Western world. And finally, our own data of more than 1,500 patients now of lipoprotein little have shown that general population has high LPA above 50 milligram in around 25% of population, which is higher than the Western world. But when we look into the coronary artery disease patient, it is 35%. And when we look into the FH population, the high LPA was highest, more than 40 to 45%. So that shows that there are areas we are different from rest of the world. And finally, the lifestyle factor, which is again a peculiar problem of our country. The sedentary lifestyle is highly prevalent in our country compared to the Western world. And when we look into the cooking pattern, the unhealthy cooking and dietary pattern, recooking, reheating the oils were again a faulty method of cooking, very prevalent in our country. And dietary patterns are also showing that instead of keeping a carbohydrate diet to around 50%, more than 60 to 70% carbohydrate diet is consumed because a significant population of our country is vegetarian. And for that reasons, with all these 5 or 6 reasons, we decided that we should have our own guideline. So we started looking into the data of our country. We look into the prevalence data. We look into the clinical trials where we participated. We look into the genetic factors, and then we also look into the response of statin in Indian population. So all those put together helped us to write our own guideline, which took us almost more than 3 to 3.5 years. And so I just want you, I'm sure you will agree with me that the need for the Indian guidelines was there to be a little different than the ESC guideline. But most of the factors were similar to that of ESC guideline. So Dr. Ahmed, based on that, we decided to have this guideline, which was published in the Indian Heart Journal, 140 page, but there is a 14 pages executive summary also. I'm thankful to my colleagues all over the country, those who helped me to writing this manuscript. So the slogan changed a little bit. We say earlier the better, lower the better, longer the better. This was very well known to us, but we have added another word, together the better. The together the better means adding statin and non-statin drugs and looking for LDL and non-HDL also together. Look for both the factor, and that's how we could able to manage, I think, dyslipidemia in the country. And this is what we thought. So overall, back to the colleagues and Dr. Amit, your final comments on the because we are finishing at 9. It's almost 9:30.
Yeah. Dr. Dani, sir, also final comments for Dr. Dani and Dr. Amit Kumar. Yeah.
Damir joined. Okay, that is come. Okay.
Yes, sir.
Yeah, go ahead, Dr. Amit. I'll speak after.
Okay, sir. I feel that Indian guideline was very essential because we are having as sir very well explained that CAD we are having at an earlier age. We are having higher prevalence of premature CAD, and our CAD is associated with high mortality rate. So definitely, even we are having LDL less 10 milligram less as compared to the Western counterpart, but we are having such high severity of CAD. So there must be something different in our population which should be addressed with our own guideline. So I agree with this quote, earlier is the better, lower is the better, longer the better, and finally the together the better. We have to use statin plus non-statin therapy, sir.
Thank you, Amit. Samir, your views? I want to.
I think nobody could have put it better than what you did just now. I was there for some patches during your talk and slides, and I think one of the most impressive concept that has come in recent years is the understanding of overall LDL, cumulative LDL exposure. And that has, I think, changed our understanding of why atherosclerosis takes place, why events take place in some people who are at a lower LDL cholesterol level compared to others who have higher LDL levels, because we do not know in the past what has been their exposure to LDL levels. This cumulative LDL exposure, I think, is a very important concept as far as prevention is concerned. So that was that William Horton's paper and that slide. You have explained it so well. And no doubt that the CSI clinical practice guidelines, which you have written, I think that that kind of comprises is very extensive and perfect as far as Indian population is concerned. Together the better. Combination therapy is the way to go. When you are, especially when you are starting lipid lowering therapy in ACS patients. But even otherwise, combination therapy works better in that sense that it brings down the LDL level faster, many times at a lower statin dose and avoiding certain side effects, more acceptable. Patients seem more confident. So I think all in all, these two messages, cumulative LDL exposure, so starting early, lower the better, because you have, which you explained, that LDL below 40 mg also doesn't have any further side effects, but has better event rate. Longer the better, because there is no point in reducing the statin dose once you have achieved the LDL target levels, and together the better. I think this gives a perfect message. Um, all in all, we are absolutely following this, and in our practice also, what you said, we do 1 week LDL lipid levels and 4 weeks lipid levels, and we see that when you use high dose of statin with ezetimibe to begin with, you achieve these target levels much faster. Sometimes even at 1 week, most of the time at 4 weeks you achieve the target level. Not when you think of bempedoic acid or when you think of other agents like dupilumab.
Thank you.
Thank you very much. I think for making me part of this, but I agree wholeheartedly with the message your last slide shows.
Yeah, thank you, Samir, for nicely summarizing everything in a nutshell. The only thing, what my suggestion was that we have made a small booklets of this guideline now, like a ESC small booklet, and now trying to circulate to all the physicians in the country, those who are practicing cardiology, because they should understand that the compliance of the patient is important. They should not unnecessarily reduce the dose unless until there is a need for that, which we so know the side effect is there, other factors are coming up. But one should learn that. So that's what probably we are trying to spread this. Our guideline this has come in a simplified way. We have not made it very complicated. Made it so that way probably if you can educate our colleagues, the physician, then probably more and more patients will be able to achieve the goals as we have suggested according to risk factors of the patients. I think this is what we thought, but we thought also that the guideline needs to be updated every 2 years when the new data comes and new evidences come, and we know that going below 40 or 30 may not be important. It may be any level if patient is tolerating well, particularly if he is an extremely high risk population. And in our guideline, we found that besides the recurrent coronary event coming within 2 years as one of the criteria of extremely high risk population, we found that in our country, in our follow-up of last 6 to 7 years, patients of familial hypercholesterolemia, which we found is not a small number, which we are missing them because we don't look for them. And this group, when we found they have high associated LPA. So that suggestion also we have given in our guideline, that one, that the majority of the patient non-fasting is good enough, because that will give more and more patient to go for their lipid profile. If you make that fasting, sometimes it becomes a challenge for them to go to the lab, and unnecessarily there is a lab rush is there. So making that become the unless until patient in known case of hypertriglyceridemia or pancreatitis, where we suggest you have to go for fasting. So one is that message came, and the second message which we gave, the first lipid profile should be done at the age of 18 in our country, not to 30 or 35 in the Western guideline what they have written, because when the child goes from a school to a college, he should also know his blood pressure, his sugar, and his LDL also, because we get this risk factor earlier in life. So this was another message which we gave, and the important thing is that the giving the right dose to a patient to achieve a goal is also very important, and for that probably educating physician colleagues is also very, very important, which I personally feel. So thank you very much, and over to Dr. Hiren and Mr. Kajinder
Sir,
to.
I just last question that I would like to ask to all of you about the risk stratification is playing very important role about making a decision of giving the right dose, right choice of statin therapy for the eligible patient. So, what do you think? What is your comments about the some risk calculation or severe stratification, especially using the TUV score or some other scores? How you will
Yeah,
look the clinical decision making about the risk score?
you can see this slide. The first sentence is written that in the absence of our own risk calculator, only risk factors have been used in making this guideline. Because unfortunately, we do not have our own risk calculator at the moment. If you use the Framingham risk score or JCB or quick risk score, all those risk or even score of the Europe, the we underestimate our risk in our population because majority, the significant number of population are getting disease less than 40 years of also. This is what we are experiencing now. So I think that's why we need to, all of us, all our colleagues in the country have to work to look into the a method of calculating our own risk factor, which is specific for our country. That is a need. I mean, we do not have any good data to make our own risk calculator. I think we have to work hard along with all the colleagues to prepare our own risk calculator of country. Then only we will able to use. Otherwise, we are using only the risk factors, which is there.
Yeah, thank you. Yeah, Dr. Rajesh, sir, you want to add here? Yeah.
Yeah, I mean, I would like to play devil's advocate. I personally believe, I mean, based on one comment which I heard from W.C. Roberts way back, maybe I think it was 10 years back or 18 years back, that what is good for acute MI patient or ACS patient, why can't it be good for non-ACS patient? If you say that LDL levels of below 70 or below 40 is important for ACS patient or for high risk patient, why can't it be good for low risk patients as well? So I would think of risk assessment in other way. What are the risks of giving HIS to this patient, or what are the risks for bringing down LDL to 40 milligram for this particular patient? If I can do that without any significant increase in risk side effects from statin, I would do that irrespective of what risk category that patient belongs to in conventional risk assessment. So if even if no hypertension, no diabetes, no family history, but a proximal LED plaque of 40% in a 40-year individual, he may not be very high risk patient. But for me, I would bring down his LDL to 40 milligram or 30 milligram or 20 milligram if I can do that without any significant side effects, without any significant risk of therapy. So that is my take. I'm
I
sure
think
it is a bit controversial, but and if you talk about community treatment at societal level, it may not be very cost effective, but for an individual level, especially in India, where each individual pays for his own treatment, I think that kind of assessment is also important.
Yeah, I think you have a point. Like I had a patient a few weeks ago, a young boy, 28-year-old, working for a MNC. His LDL was 144. And he said he has read through Google everything. He went for lifestyle, extensive lifestyle modification, exercise, reducing his cholesterol, diet. And when he asked him about the family history, he said no family history, no diabetes, no hypertension, calcium. He got his calcium score, which was zero. I mean, so everything. And then he said, doctor, why don't you put me into statin? Why don't you give me statin? So, so that became a challenge to us. So we have been trying to use, sometime we have been using in the past some of the nutraceuticals in such population, thinking that some of this drug, hilicetrol or the Chinese yeast rice and all those things can also reduce LDL cholesterol. But why not statin? So then question came, why not non-statin? If you fear the statin's side effect, like for example, new onset diabetes or myalgia, why not give ezetimibe? Why not give bempedoic acid to this individual, which probably is a more safer drug? And now I am using for such population, thinking that the, as we have just discussed in first slide, it is a lifelong exposure of the LDL cholesterol, which makes ultimately atherogenesis. So why not start early? That's what we thought, that a guideline to start lipid at the age of 18 to begin with. And if the levels are high, anyway, I have only day for not last week, 4 days ago, I took start statin for a boy 5 years and 4 months old. He's just 5 months and 4 years, 5 years and 4 months old boy from Gwalior. He is on statin now because the reason is his father got heart attack at the age of 36, uncle at 38, grandfather died at 47, and his LDL is 273. The child's LDL is 273. I did the genetic studying, which is available in our hospital, and it turned out to be ApoB positive genetic mutation. So then what to do? The mother asked me that what will happen if you start statin, growth will be problem, or it will be sexual development will be problem, all those things. We showed them the literature that it does not, rather it helps them. So the child is now on, I put him on 4 milligram of pitavastatin, and let's see the result. It's just a few days old story. And so that's why I think the data on children is now available, which shows that the drug is safe even in children. So starting for other, that I was saying, the boy 20-year-old, putting him instead of nutraceutical or in a small dose of statin, probably may be worth if you want to reduce. And Dr. Brown was nice paper that give inclisiran 1 injection a year, which will be like a vaccine, probably reduces cholesterol by 20%. If you give 2 injections a year, it reduces by 50-55%. But if you give 1 injection a year after an initial 2 injection, then probably 20% will be reduced. So if such type of child, which who came to me 28-year-old, I will be very happy to put him on 1 injection of inclisiran, and probably keeping his LDL below 100 will probably prevent him. That will become more practical because this inclisiran is more safer and do not have any side effect, unlike the statin. So this is what I thought. It can be given. And Samir, your point is right, that if you're looking for secondary prevention, why not for primary prevention? But we know that the primary prevention people, their chances of developing cardiovascular disease is less because of the follow-up data, unfortunately, not available. Only Mendelian hypothesis research is available for more than 5 decades, where they have shown even in primary prophylaxis people, if they keep their LDL level low as early as 4 years or 5 years, then naturally they are getting disease only at the age of 85, 90. So there is a definitely rational, as you rightly said. But giving inclisiran 1 injection may not be afforded by many people. That's the issue.
That's why at societal level, it may not be a good strategy, but you have to individualize.
Yeah, individualize. You have to that. I think you're right. So I think.
So I think it was a nice discussion. With your kind permission, I think then we close the meeting, sir.
Thank you. Thank you.
Yeah. Thank you, Dr. Dr. Shivani sir. Thank you, Dr. Samidani sir and Dr. Amit Kumar sir, for giving your wonderful insights and sparing your time for today's evening, for making this webinar a great success. Thank you. Have a good day, sir. Good night.
Good night.
Yeah, thank you so much, everyone. So from here, I'm ending this meeting. Thank you.
Thank you.
Good day. ये कैसे स्टॉप शेयरिंग होगा? स्टॉप शेयरिंग कैसे होगा? चलो भाई चलो।